All right, everybody, thanks for joining us this afternoon. Very happy to introduce Dr. Stuart Prenner. Dr. Prenner is joining us from the University of Pennsylvania, where he's an assistant professor of medicine. He is the program director of their Advanced Heart Failure and Transplant Cardiology Fellowship Program and serves as the medical director of the Heart Failure with Preserved Ejection Fraction program at their facility. Very happy that he's going to talk to us about this a topic which is becoming more and more important. And Dr. Prenner, thank you again, and the floor is yours.
Thanks so much, Mike, for that kind introduction. I have probably much more material than I can cover in 25 minutes, but we can make this available to everyone. I'm also going to try some interactive opportunities, and we'll see how it goes. So please avail yourselves of those. So we're going to talk a little bit about the epidemiology of HFpEF and the impact of quality of life, but really the focus of this is going to be on the pathophysiology and making the diagnosis, because I think if you can do that, you're like 90% of the way there. And this is an area that has really evolved over time. And I think as guideline writers and as a field, we have really not made it so straightforward to kind of work this up over the last decade and a half. So it's important to remember that HFpEF is situated in a description of heart failure classifications that is a distinct entity from other forms of heart failure, namely HFrEF, heart failure with mildly reduced, and heart failure with improved EF. And more recently, we are reminded that the universal definition of heart failure, particularly for patients with EFs of over 40, requires us to document that there's manifest congestion, right? If the heart's going to be the cause of a patient's signs or symptoms, there needs to be some evidence of congestion, either at rest or with provocation. And the universal definition of heart failure encompasses this, and it's particularly relevant for HFpEF, right? Because if the EF is preserved, how do you know that the heart is the cause of the symptoms? And so either this is demonstrated through natriuretic peptide levels, which we'll talk about, or documenting congestion either at rest or with provocation in the echo lab or in the cath lab on physical exams now. And so when I'm thinking about how to define HFpEF, I refer to this slide here, which is that it's a clinical diagnosis. So patients should have signs and symptoms of heart failure, right? And this gets back to the Framingham criteria of how we think about heart failure as a clinical as a clinical diagnosis in terms of edema, exertional intolerance, or weight loss that's rendered with the administration of diuretics, elevated neck veins, et cetera. We need to make sure that we're not dealing with valvular heart disease, particularly severe valvular heart disease. And we also need to make sure that the ejection fraction has never been low. So this is not the same thing as someone whose EF has been low and has remodeled heart failure therapy. So that's a separate issue. And then the last piece of this, and I think this is really the key takeaway from this part of the talk, is that we have to document congestion. You have to document that somehow there's a congestive issue that's at the crux of the patient's symptoms. And for HFpEF, this can be challenging, particularly in earlier stages of the disease when there may not be manifest congestion on physical exam or in the cath lab or on echo at rest. And so one important sort of pathophysiologic principle to just say outright is that HFpEF does not sort of devolve into HFrEF. So HFpEF is not like a precursor to HFrEF. This slide shows a cohort from Italy, which was followed over 10 years. And you can really see that in general, the EFs remain preserved. And in a small subset of patients where the EFs did drop, as you can see on the right, the reason for that was some sort of intercurrent ischemic event. It was not otherwise the natural history of this disease to devolve into low EF over time. And so why are we talking about this? Well, we're talking about this because HFpEF is on the rise. The incidence and prevalence are both rising, partly because of the aging of the population and because of the tremendous burden and of hypertension and obesity on the incidence of HFpEF. And so this is just a schematic that's meant to show us that even 10 years ago, we were predicting where we are now, which is that the HFpEF is really representative of more than 50% of heart failure diagnoses in the community, and particularly in patients over the age of 80, 90% of heart failure is associated with a preserved EF. So this is a condition that is going nowhere, and in fact is only going to be more prevalent over time. The other reason we're talking about it is because the significant impact on quality of life. So it might surprise you that if you actually look at the KCCQ functional scores in patients from the two ARNI trials, Paragon in preserved and Paradigm in reduced, the distribution of symptom burden in the trial participants basically mirrors one study to the next, meaning that patients with preserved EF are as functionally limited as their HFrEF counterparts. And there are other studies using VO2 and other indices that suggest that the typical patients in HFpEF clinical studies have a functional capacity that's basically barely over the level of functional independence at about 4 METs. And so this is a significant impactor of quality of life. And so when we talk about the pathophysiology of HFpEF, I don't think it's so straightforward. And one of the principles to at least talk about, because this could be a whole separate lecture, is the fact that we used to just talk about diastolic dysfunction, and we would say, okay, well, as you get older, you have AH and you get diastolic dysfunction, and that's literally all HFpEF is. It turns out it's much more complicated, and we know from endomyocardial biopsies of patients with HFpEF that even compared to controls with just hypertension, these patients have marked derangement in signaling pathways, most of which are involved in inflammation. And so Walter Paulus and some of his colleagues in the early 2010s basically turned this field on its head by suggesting that HFpEF is really a manifestation of systemic inflammation, and that the heart is one of many organs that's affected, but including skeletal muscle, the kidney, and the lungs. And part of the way that we know this is that inflammatory markers are very, very elevated in these patients, and they're very different in terms of their profiles from HFrEF. And so again, this could be a whole other talk, but I think this principle is very important in terms of who gets HFpEF and in terms of some of the therapies that actually have been efficacious. And this is just a central illustration from a relatively recent JACC article just highlighting this, that HFpEF is a multi-organ dysfunction syndrome that's driven by aging, comorbidities, and other aspects that lead to frailty, and that together this impacts the quality of life and functional impairment that these patients have. The other way that we have thought about this is that once these patients develop HFpEF, we really see a spectrum of disease that initially starts off, if you look at the left side, with really an exercise-induced LA hypertension. So these are patients who probably do not have elevated BNP levels. If you took them, for example, for just a resting right heart cath, you might not be able to document abnormalities because it's only with exertion that the disease manifests. But over time, we see significant remodeling of the heart to really a bisided process where you'll end up having LV and RV and RA enlargement. And that phenotype can sometimes be irreversible. So my point is there's a spectrum, and unfortunately what we end up catching is really this advanced phenotype on the right where patients end up hospitalized and are missing a lot of earlier disease that's kind of lurking in our clinics. Another principle to share is that even if ultimately the symptoms are due to elevated filling pressures either at rest or with exertion, the reason these patients become symptomatic differ one to the next, and there are numerous mechanisms that are highlighted at the top of this slide, each of which I think could be its own talk and can drive the disease in particular patient populations. So one of the reasons that natriuretic peptides can be challenging to use in the diagnosis of HFpEF is because, in contrast to the myopathic heart on the left, which is dilated and the wall is very thin, The typical HFpEF heart on the right is normal sized and with a thick wall. And so that wall stress is much less if you see as the equation on the bottom. And so these hearts are not necessarily a setup to lead to BMP secretion. The other issue is that these patients can be obese. And so our first interactive slide, if everybody can do the QR code here, is basically asking folks what percentage of patients with proven elevated wedge pressure in the cath lab, even at rest, with HFpEF will have a normal BNP. What percentage of patients with HFpEF and an elevated wedge at rest have a normal BNP? So if you can take the QR code and do it, hopefully we can actually see the results right now. All right, so people are chiming in. Let's take a look. Give it one more minute. So good. So most folks are identifying the fact that a substantial percentage of patients with HFpEF have normal
I think you
BNP.
need to, sorry, I think you need to change what slide you're sharing with us so we
Okay.
could, if you're seeing it, because we don't see it. We still just see the QR code.
How about
Yeah.
now?
Yep, that's good.
Yeah. So most folks identified the fact that a substantial number of patients have normal BNP even when their wedge is over 15 at rest. And Sanjeev Shah's study from Northwestern, which were patients who had been previously hospitalized for HFpEF, put this number at least 30%. So this is really important because if you are relying on natriuretic peptides to rule this in or out, it's going to mislead you because this biases in the low direction. Okay, so the other concept to talk about is the fact that at least in garden variety HFpEF, patients have typical comorbidities, meaning there's a particular flavor of comorbidities you expect to see in this patient population. And so if everyone can now do the QR code and just type in some comorbidities that come to mind when you think of who gets what we'll call garden variety HFpEF, not something rare or a zebra, but kind of the typical flavor.
It's still showing the previous question.
What about now? In the QR code you're saying?
Yes, sir.
So it's not advancing. Is there a different QR code? Or, oh, I see what I have to do. Okay, give me 1 second. What about now?
Can you share your screen, please?
Okay, what about now?
It's still showing the previous question.
Is it showing you my full screen?
Yes.
All right.
Stu, I think what you need to do is you have to go to the, like for the on Menti, if you go to present it and then you advance to that slide, then it's going to activate it on the phones. Yeah.
Are we seeing it now?
Yes.
Okay, great. But you guys can't see my screen now, but people can at least chime in.
Correct.
Okay, perfect. Okay, so good. And I apologize for any difficulty this is causing, but I wanted to do this. So we've got a couple responses. Keep going. 5 responses so far, and I'll share my screen now. And hopefully everybody can see this. Give me 1 second. Okay, good. Can everybody see this right now?
Yep.
Yeah.
Perfect. So you were seeing CKD, obesity, AFib, age, and diabetes. So perfect. So let me go back to my talk now, and we'll pick up where we left off. Great. Can you guys see my talk now?
Yep.
Yes, sir.
Perfect. So you guys were right on the money. And so the reason this is important, right, is because when you're working up HFpEF, especially in its garden variety sense, the expectation is that you're going to see a certain pattern of comorbidities, which you guys highlighted. Typically patients in their 60s and 70s, invariably hypertensive, half are diabetic. This is just from the Paragon study, and like 30 to 40% have AFib. And the reason this is important is because these comorbidities are incorporated into some of the scoring systems that we use in order to determine pretest probability. So 95% of people with garden variety HFpEF have either diabetes, hypertension, or obesity. And one of the red flags when I'm working this up is if a patient is trying to be sold as HFpEF and they don't have these comorbidities, I'm already thinking that there may be a mimicker or some sort of other diagnosis going on. And these comorbidities are incorporated into one of the scoring systems that we use, which is the H2FPEF score. So in addition to some variables that are taken from the echo, patients get various points for being overweight, hypertensive, having AFib or age. And if this score approaches 6, the pretest probability of HFpEF as the cause of unexplained dyspnea, so not dyspnea in someone with 40 pack years of smoking, but truly somebody who has unexplained dyspnea, is quite high. The other risk score that comes out of Europe is the HFA-PEF score, which is calculated entirely from echo and biomarker parameters. And you can see here that you get major or minor criteria depending on the derangements in filling pressures or structural remodeling, all of which, again, is meant to get at congestion. And that's why I'm focusing so much on this. These are markers of congestion, E over E prime, BNP, these are markers of congestion. You get 2 points for major and 1 point for minor. And if you get to 5 or greater, high pretest probability. These risk scores also are associated with worsening prognosis in the outpatient setting, even in patients who have unknown history of HFpEF. And this is some work from Senthil Selvaraj showing that as these scores are serially elevated, patients have a risk of heart failure hospitalization that approaches those who have already been diagnosed with HFpEF. So it's very important to calculate this. And so if you're thinking about an algorithm, right, the first thing to do is to be suspicious and then to document congestion, okay? If you can document congestion either because the BNP is up or they've had a heart failure hospitalization, you're pretty much there. If you can't document that, then basically what you should do is turn to your echo and turn to your risk scores and determine whether they put you in a very high pretest probability or a very low pretest probability. Ultimately, most patients kind of declare themselves, but if they haven't, that's when you proceed to advanced testing. And I will hope to make the argument that really an exercise right heart cath is where you should go. In terms of the guidelines, the heart failure guidelines were updated in 2022. And what's very exciting is just like HFrEF had multiple figures to sort of tell us how to treat, we now have one for HFpEF, which has identified the use of SGLT2 inhibitors as really the standard of care once you diagnose this condition, with lower levels of indication for ARNI, MRA, and ARB. I will call your attention to the fact that the 2 major studies in SGLT2 inhibitors, DELIVER and EMPEROR Preserved, ironically showed different patterns of response to the drug depending on where people's EF was. But ultimately, and taken in totality, they really support the use of this drug category for all patients with HFpEF. ARNI, if you noted, got a 2B level of evidence. And if we look at the Paragon study, overall, it barely missed statistical significance with a p-value of or hazard ratio of 1.01. But if you looked at the response by median ejection fraction, patients with EFs at the lower end of normal seem to respond. And interestingly, women seem to respond more than men. And so some of the guidelines and position statements have really emphasized the use of this drug class, particularly in people whose EFs are on the lower end of normal. And part of me wonders if some of the attenuation at the higher ends of EF was either for patients with like hypertrophic or other infiltrative issues and sort of bias the results a little bit. That's my own opinion. I don't know that we'll ever know. And so with the last couple minutes here, I want to highlight how the nuances of the management of this are really how we work these patients up in our HFpEF clinic. And so HFpEF has a broad differential diagnosis, right? So if you simply define the disease by having congestion and an EF that's normal, a lot of things fall under that bucket. And so I'm hoping with our last QR code, folks can do a differential diagnosis and just type in what conditions fall under that. And so here's our last thing for HFpEF mimickers. So if folks can type in things that fall under this disease category that need to be excluded before you just sort of label the patient as having garden variety HFpEF. All right, so hopefully you guys can see the screen now. So we have amyloid, we have HCM. Mike, if I go over by like a minute or two, will the talk like stop or am I okay?
No, you're good. It'll keep going.
I get very excited about HFpEF. Fabry's disease, wonderful. All right, so I'll stop sharing there, but those are great mimickers. And let me go back to the PowerPoint. Wonderful. So here's a good schematic for thinking about the differential diagnosis, and it partly depends on whether there's increased LV mass or not. When there's LVH, we think about amyloid, Fabry's disease. You guys hit both of those, HCM. When the LV is normal sized, right, we have to entertain the fact that, again, if there's congestion with normal EF, are we dealing with restriction? Are we dealing with pericardial disease? And I've seen every single one of these in my clinic. I've seen HCM, I've seen pericardial disease. Restrictive diseases are a little less common, but we've absolutely seen them. And the other framework to keep in mind, which is why we had the prior slides focusing on typical comorbidities, is that one of the doesn't have those conventional risk factors. So they're in their 40s, they're in their 70s, but they've never had a history of hypertension. That's really, really unusual. And then the other thing is a high BNP level. So unlike HFrEF, it's relatively unusual, partly because of obesity. And again, because of what I showed you with the data to see patients with HFpEFs and BNPs over 1,000. Can we see it? Absolutely. The typical phenotype is a thinner patient with AFib. But when you start seeing sort of 4-digit BNPs, you absolutely want to be thinking about amyloid or other infiltrative issues. And then the other, right, is sort of the intolerance to GDMT, right? That patient with, a thick LV that's kind of intolerant to antihypertensives makes you think about amyloid. When you see conduction issues, you think about sarcoid. And then when you see that right-sided structures are larger than left-sided structures, it also makes you worry a little bit about, for example, a shunt or things like pulmonary hypertension. I'll skip this slide in the interest of time. So again, we get back to our algorithm, which is, okay, so you've ruled out a lot of other things. You've done a stress test. You're not dealing with valvular heart disease. The patient sort of examines so-so, and the BNP is, say, 100, which is so common. And you calculate a HFpEF score, and they're kind of intermediate, right? Ultimately, where these patients are best served, in my opinion, is in the cath lab and with exercise hemodynamics. And so our protocol I just wanted to share for you is basically to use a 7 French Swan catheter, which can do both thick and thermodilution. You need the thermodilution, right? Because as the patients are exercising, you can't compute the cardiac output using thick because you don't know what their O2 consumption is. And then what we do is we do resting numbers, and then we put their legs in a bike. And we take more measurements before they even exercise. And then we do a ramp protocol where they do graduated exercise every 2 minutes until they're basically maximally exerting themselves. And then very rapidly, they try to tell us when they're about to tap out. And we try to get the exertional hemodynamics very, very quickly. Why? Because we know that in most patients, the filling pressures can rapidly normalize. And if, for example, you wait even a minute to get them, you'll miss the diagnosis in a lot of patients. And so the cath criteria for diagnosing HFpEF are a wedge of over 15 at rest, which you won't see a lot of in early disease. A wedge of over 25 with exercise, or an abnormal rise in the wedge pressure relative to the cardiac output. And so that requires a couple of measurements to compute. The other thing that's helpful is to calculate the heart rate and blood pressure response to exercise, because there are a lot of clues there in terms of what mechanism may be driving the rise in the wedge in your particular patient. And so Barry Borlaug's group interestingly showed that you may not be able to do a full exercise right heart cath. Maybe your lab can't do it, right? But what he showed is that if you put your legs up in the pedals, that alone causes enough venous return that for many patients, you can actually kind of adjudicate the hemodynamics just on that basis. And what he showed was that if with a passive leg raise, your wedge did not go above 11, none of those patients ended up ruling in with the full exercise protocol. And conversely, if the wedge went to over 19, all of those patients ruled in. This was a small sample size, and I don't think the standard of care is to just do a leg raise, but it's compelling that I think if the lab, for example, can't do it, you need to do some provocative maneuver, right? You're going to miss this disease because it's an exertional disease early on if you don't do some provocative maneuver. Saline bolus, leg raise, something. I want to leave time for questions, so I'm going to try to wrap this up in the next couple of minutes, but here's a good example from my patient cohort, right? So patient with a wedge of 14 at the top at rest, right? So he doesn't make any diagnosis here. It's below 15. We put his legs up in the bike. I don't know that he gets to, Barry's cutoff of 19, but what he starts to develop is a V wave, which is interesting because he doesn't have MR. So even with just the legs and the bicycle, the contour of the left atrial stretch is apparent. And then he starts exercising and kind of all hell breaks loose, right? The wedge, clearly goes to about 25. And look at these V waves. This guy does not have MR. Right. And so we're eliciting this left atrial myopathy in a guy who's been ablated multiple times by exercising him. So it's important to get the diagnosis right. And so hopefully with the algorithms I've presented you and your ability to rule out mimickers, you will sort of get patients kind of put into the right bucket. And then the last thing, and I'll end here, is to figure out what the process is that's causing their symptoms, right? Even if the downstream effect is a wedge pressure that's inappropriately elevated either at rest or with exercise, the mechanisms that underlie that may differ one patient to the next. And so that's where, for example, paying attention to what the heart rate, the blood pressure, the O2 saturation do with exercise can be very telling. And I'll tell you that if you look at my patient's exercise cath, equally as important to what his wedge does is the fact that his heart rate barely got to 80 with 9 minutes of exercise. This patient was probably over beta blocked, and that might be one of the things that helps him. The other, right, are things that help us deal with congestion, right? So we know that PA sensor guided management is indicated for patients with ongoing symptoms who have either had a heart failure hospitalization or natriuretic peptide issues. It's hard, right? Because we talked about the fact that BNP frustratingly remains the way that many of these patients qualify for therapies, and yet is low disproportionately in even some of the sickest patients. And then we have to treat comorbidities, right? So the last piece of this is that even though the heart failure may be a target organ manifestation of a systemic process, the comorbidities matter almost as much as treating the heart itself. AFib is a common one, and obesity is a very common one. And so I will just remind folks that the STEP-HFpEF study showed significant benefit in the use of GLP-1 receptor agonists, not just for weight loss, but actually for improvement in KCCQ and actually in functional endpoints. And we enrolled in this study. And interestingly, one of the things that was shown was actually a reduction in BNP levels across the duration of the study, which is interesting because if you think about weight loss, if weight loss was sort of the only way that these patients benefited, the BNP levels might be expected to go up, as we discussed, with obesity driving them down. So something about weight loss actually seems to be changing some of the natural history of HFpEF above and beyond just the weight loss. And so I'm going to end there. I know the last couple slides were a little bit of a rush, but it's hard to present HFpEF in 25 minutes, and I want to leave a couple minutes for questions. So Mike, thanks so much for having me. It was really a pleasure to present to everybody, and I'd love if there are a couple questions from folks.
Yeah, we've got actually a list of questions for you in the chat already. So
Yeah.
uh, we'll start from the top. So the first one was, can we call HFpEF just pulmonary hypertension with atrial cardiomyopathy?
So it's a good question. I think I always want to be careful about how we label pulmonary hypertension, particularly because of the implications, partly for patients, right? If we all agree we're dealing with pulmonary venous hypertension, then I think that's fair. I think we do need to be careful about the labeling. And I think the implicit description there is that you've either made a diagnosis of pulmonary hypertension by echo, right, using an elevated PASP, but ideally have gone to cath. And so I think you're absolutely right that when we see elevated PA pressures in a patient with a dilated LA, for sure you're dealing with HFpEF 99 times out of 100. But I think in order to keep things pure, I think we should distinguish the two, because both for patients and I think for consultants, it's important that everyone agree we're dealing with pulmonary venous hypertension. But I think it's a great point.
The next one I think is probably asking for your opinion on the use of MRAs and the evidence from the TopCat trial.
Yeah, so 2 points to make there. One, obviously, as everybody knows, TopCat was a flawed study. If you look at the America population, there was clear mortality benefit. That being said, one of the signals that came out of TopCat was that the effect of the MRA was attenuated in people who had the higher tertiles of BNP. And so one of the ways to interpret that, right, is not that it's sort of too late to do, but you also have to remember that that therapy was not studied in patients without elevated BNP. And so we need to remember the framework in which studies were done. I think MRAs are wonderful drugs as adjunctive antihypertensives, but I think we should lean on some of the other therapies a little bit more, particularly SGLT2 inhibitors. And I think the strength of recommendation in the guidelines reflects that.
Can you talk about the relationship between sleep apnea and HFpEF? Is it sleep apnea? I mean, it was there on your comorbidity slide. Is it a risk factor for HFpEF, or something that just needs to be treated if you have HFpEF? And how does that also relate to their risk for pulmonary hypertension?
Yeah, so that's a fantastic question. And I think the jury is still out a little bit. We actually just published a retrospect paper from here showing that in patients referred for echo and sleep study, so again, it's a selected patient population, HFpEF risk scores strongly associated with severity of sleep apnea. What we don't have is prospective data, and as everyone's aware, right, it hasn't been totally clear that applying CPAP therapy totally reduces heart failure endpoints, and we've actually been burned a little bit in terms of central sleep apnea. So we need to be a little bit careful there. What I do think is the case is, particularly for patients who have symptoms that could be from sleep apnea, treating it makes sense. For patients with paroxysmal AFib, it makes sense. And I do think there are patients for whom the degree of PA pressure elevation is definitely related to sleep disordered breathing. I think it would be a little bit too far to say that like putting on CPAP therapy changes the natural history of HFpEF directly, but indirectly sense that it wouldn't. We need more studies. So I think that's a great question. And I think all of these patients should be referred for sleep apnea. My hit rate, I would say, is almost 100%. I don't know, Mike, what your take is, but like there's just such an overlap in comorbidity, and most of it's driven by obesity.
Yeah, I would agree with you there. I'm going to combine two questions here because they're kind of similar. So
Sure.
basically commenting on the role of rate control in HFpEF, and also later talking about, how beta blockers were not included in that recommendation about different forms of medical therapy for HFpEF in the recent heart failure guidelines. What would your thoughts be there? And I think just to kind of add a little more to this, I guess, would be, because this is kind of where I kind of get into this conundrum a little bit. If you do have somebody with paroxysmal AFib and you want something there for rate control just in case they go into AFib, what do you do then? Because I think otherwise I tend not to use anything with rate control, 'cause as I think you probably would agree, these patients tend to feel better at a little bit of a higher resting heart rate.
I think you're absolutely right. And again, I think part of it is making sure you're not dealing with a frankly restrictive cardiomyopathy, right? Something like amyloid. But I think even in the more garden variety sense, right, it cuts both ways, right? AFib for sure is an important comorbidity, and that's where we have to work with our EP colleagues, right? Because all patients aren't created equal, and we actually can assess for these things. So even the JACC paper that randomized patients, they didn't randomize, it was a crossover to coming off your beta blocker. They actually had a metric called the chronotropic index, which can be calculated using the patient's age and basically what their heart rate does during a submaximal VO2. So there are actually metrics that tell us how chronotropically incompetent a patient is. And the reality is there are patients where you can't really thread the needle, right? They have paroxysmal tachycardia, but they also are at baseline bradycardic, and those are patients that may need devices. So I think it's an evolving landscape, and actually, the Cabana program is actually doing a study in HFpEF, so more to come. It's a great question. My sense, to your point, Mike, is I think less is more for most patients, particularly come in on these very, very high doses, 25 of COVID, atenolol, high doses of beta blockers, sometimes just cutting them in half, with the blessing of the EP doc can go a long way, just as even an experiment.
And then our final question here will be, how about an increased LV-EDP after PVC during a left heart cath? And also, can hand grip at that time be sensitive enough to increase or elicit a rise in LV-EDP? I guess alternative means of assessing kind of what you were talking about with your exercise diastolic stress test.
Yeah, that's a really good question, and I think it's a little bit nuanced. I think the standard of care really is to exercise patients because it's the closest thing we have to kind of provoking sort of the physiology that's at play when they're moving around. I think your points about hand grip and other things are interesting. The problem with things like hand grip is that the physiology is a little different from exercise. Simply increasing SBR as kind of the only mechanism may not totally be comparable to kind of an exercise response that involves chronotropic elements as well as others. And so I still favor doing that, but I think the spirit is there, right? In terms of, talking with your lab about what they can do. And it may be that the leg raise is actually, for Barry's work, maybe sort of almost enough. So it's a good question. Arrhythmias, you're right, make it challenging in terms of kind of the post arrhythmia augmentation and kind of what to do about that. So I think every case is different. I think if you're thinking about getting the patient to the lab, you're like 99% of the way there, because that's where the devil's in the details. So I think these are great questions, and more to come.
Yeah. All right. Well, Dr. Prenner, thank you so much. That was very exciting, and I think this is awesome because for so long HFpEF was kind of like the boring stepsister of HFrEF, but as time goes by, I think HFpEF has so much more interesting things coming about, science and treatment and all the clinical management. So it's definitely a bit more of a cognitive workout sometimes managing these HFpEF patients, and I think you showed us all why that is. So thanks so much for the time and the great talk.
That's my pleasure. Thanks for having me.
Bye bye, everybody.